Alright, the second chapter we're going to talk about this week is chapter 7, the urinary system. This is some review about A and P. So the urinary system consists of 2 kidneys, 2 ureters, a bladder, and a urethra. Its main function is to remove waste from the bloodstream for excretion and forming urine. This is a highlight star. Kidneys are the site where the urine is formed and excreted through the process filtration and reabsorption. The kidneys are retroperitoneal and are normally located between the 12th thoracic vertebrae and the 3rd lumbar vertebrae. The right kidney sits slightly lower than the left due to the position of the liver. The area where structures enter and leave the kidney is called the hilum. These structures include the renal artery, vein, lymphatics, and a nerve plexus. The nephron is microscopic and is the functional unit of the kidney responsible for blood filtration and formation of urine. Each kidney has approximately 1 million nephrons. The nephron also houses the glomerulus, Bowman's capsule, and numerous convoluted tubules. The minor calyces join to form the major calyces, which combine to form the renal pelvis. This is referred to as the renal collecting system. This is more review. The ureters extend from kidneys to bladder and function to drain urine from kidneys to bladder. Urinary bladder acts as reservoir to urine and is located behind the symphysis pubis. So this is another highlight star. We are going to talk about imaging considerations. So urinary disorders can be discovered through lab tests or clinical findings. Clinical findings include frequent urination, excessive urination, low urine output, painful urination, or obstructive symptoms. Urine may also have an abnormal color. Patients may experience kidney pain in the flank or back at the level of T12. Bladder pain resulting from cystitis is usually limited to the urinary bladder. Kidney functions need to be evaluated before administering IV contrast agents. These include blood urea nitrogen, which is BUN, glomerular filtration rate, which is GFR, and estimated, which would be eGFR. Those are the lab tests. Creatinine is a waste product derived from the breakdown of a compound normally found in muscle tissue. BUN levels are influenced by urine flow and production and metabolism of urea. It's measurement for how well the urinary system can break down nitrogenous compounds from proteins to produce urea nitrogen. When administering contrast, eGFR is used as the main lab value when determining safety of IV contrast. Contrast agents should not be used on those with a BUN that is greater than 50 milligrams or a creatinine that is greater than 3 milligrams. There is currently no threshold established for GFR levels, but it should be greater than 90 milliliters per minute. For KUB radiograph, kidney, that stands for kidneys, ureters, and bladder. This is useful in demonstrating size and location of the kidneys. These organs may be visible on radiographs because of the perirenal fat capsule that surrounds them. Evaluating the kidneys this way is limited because the shadows may be obscured by bowel content and are difficult to visualize due to the low subject contrast in the abdomen. KUB is usually the first step in radiographic urinary studies like an IVU or IVP to determine that there is adequate bowel preparation. Visualize radiopaque calculi of kidneys, ureters, or bladder. This should also be reviewed from something that you learned in the fluoro unit. So an intravenous urography exam is done to assess the urinary system. This is a functional exam. The indications for this exam include flank pain, calculus disease, suspected urinary tract obstruction, abnormal urinary sediment, systemic hypertension, UTIs, screening for congenital genitourinary anomalies, or history of transitional cell or renal cell carcinoma. This exam does utilize contrast agents. Routine IVUs call for images to be obtained within 30 seconds to 1 minute after IV contrast is injected. This phase is called the nephrogram phase and can be used to demonstrate the contrast agent in the nephrons before it reaches the renal calyces. Other time-delayed images can be taken at 5 minutes, 15 minutes, but varies from institution to institution. A post-void image is taken at the end of the exam. This image provides info regarding decompression of the urinary tract after emptying the bladder. The renal pelvis, calyces, ureters, and bladder are examined for any abnormalities during the exam. This is a highlight star. So a cystography, aka retrograde cystography, is a common radiographic exam for studying the lower urinary tract. It involves inserting a urinary catheter through the urethra into the bladder to facilitate retrograde filling of the bladder with contrast. Projections include AP, LPO, RPO, and lateral, and may be done with the patient supine or upright, depending on why the study was ordered. Indications for this procedure are vesicoureteral reflux, or VUR, with congenital bladder and anomalies and post-op. VUR occurs when the ureteral valve does not function properly and allows urine to reflux back up the ureter. Avoiding cystourethrogram is sometimes used in conjunction with a retrograde cystography to allow visualization of the urethra during voiding. A VCUG is often performed to assess for VUR. This is also a functional exam. Retrograde pylography, or RP, requires the placement of a catheter into the ureteric orifice in a retrograde fashion. This is performed by a urologist during a cystoscopy. The exam is referred to as a retrograde because it involves injecting contrast into the ureter into the affected kidney opposite the normal direction of the urine flow. Indications for this exam include hematuria, hydronephrosis, and when evaluating a non-functioning kidney, it is to find out more information about any possible obstruction. Imaging for this exam can include radiographs, but since this exam is normally performed in surgery, it is more common to use a C-arm with fluoro. Ultrasound is really the imaging modality of choice for most renal disorders. So like I said in the last slide, ultrasound is used for most renal disorders. There are also advantages of using CT to evaluate a kidney is it can detect smaller differences of 1% or less, evaluate small lesions, determining the nature of renal masses, either solid or cystic, which might not be seen on radiographs. Contrast is used in a variety of ways with CT. It can be used with, without, or combination of the two. CT is useful in looking for renal calculi, retroperitoneal masses, assessing renal infection or trauma, evaluating chronic pelvic pain, and staging malignancies. Ultrasound is also used to evaluate the urinary system. This is also a highlight star, so urinary tubes and catheters is what we're going to talk about now. Nephrostomy tube is connected to the renal pelvis to the outside of the body to allow urine to drain outside of the body. Precautions must be taken with nephrostomy tubes. Patients are susceptible to infections because of a direct opening into the urinary system. Ureteral stents are placed for ureteral obstruction. They are placed surgically with the upper portion of the stent located in the renal pelvis. Urinary catheterization are placed through the urethra into the bladder to obtain urine specimens, relieve urinary retention, monitor renal function, and manage urinary incontinence. Foley catheters are the most common indwelling urinary catheter. They are placed using sterile technique. Precautions to be taken are to prevent UTIs. Suprapubic catheters are used for those who require long-term catheterization. Instead of a catheter being placed through the urethra, a puncture is made through the skin and muscle into the bladder, just above the symphysis pubis. We're going to talk about congenital and hereditary diseases. So this is a highlight star. Fusion anomalies of the kidneys can often be seen on plain radiographs. The horseshoe kidney is the most common fusion anomaly, affecting 1 in 400 live births, with males affected twice as frequently as females, and are higher in those with Down syndrome and Turner syndrome. Horseshoe kidneys occur when the lower poles of the kidneys are joined across the midline by a band of soft tissue. This connection causes the kidneys to rotate on one or both sides. Kidneys normally function without any impairment of it. If an obstruction were to occur due to the ureters being in an abnormal location, a pyeloplastic surgery may be required. Cross-fused ectopy is uncommon, but it is the second most common fusion anomaly. It occurs when one kidney lies across the midline and is fused with the other kidney. Both kidneys will have differing anomalies with position, shape, fusion, and rotation. The condition is usually asymptomatic, but it could cause drainage issue with malposition of the ureter within the renal pelvis, which could require a surgical procedure called a pyeloplasty. Also a highlight star, so the position anomalies of the kidneys. Malrotation refers to the incomplete or excessive rotation of the kidneys as they ascend from the pelvis in utero. Normally this is not an issue unless an obstruction occurs. Ectopic kidney occurs when one is out of its normal position. This occurs in 1 to 1,000 live births. Normally the kidney is in the pelvis or sacral areas of the body, referred to as the underascent. Rare cases where the kidney is in an intrathoracic location, the kidney is referred to as overascent. Usually asymptomatic, however, this condition can be associated with a UPJ obstruction, VUR, and decreased function. Stone formation can be more frequent and urinary drainage is impaired. Nephrotosis is also known as kidney prolapse, and this can occur in people who are lean and athletic. This kidney can be mobile and may drop toward the pelvis when the person is in an erect position. This is distinguished from a pelvic kidney by the length in the ureter. If the ureter is short, it is a congenital pelvic kidney. Lower tract anomalies. Ureterosil is a cyst-like dilation of a ureter near its opening into the bladder. It may be the result from a congenital stenosis of the ureteral orifice. In imaging, a ureterosil appears as filling defect in the bladder with a characteristic cobra head appearance. If an ureterosil appears with a ureteral duplication, it can lead to obstruction and kidney infection. It could also lead to renal failure. Treatment involves an endoscopic or open surgical repair to allow for increased flow of urine into the bladder. More often than not, ureterosils are a coincidental finding in adults. Ureteral diverticula represents a dilated, branched ureteric remnant. They appear as like other diverticula and is best demonstrated in retrograde urography. Bladder diverticula may occur as congenital deformity or can be caused by chronic bladder outlet obstruction and resulting infection. Most common middle-aged men with benign prostatic hyperplasia may be diagnosed by a cystography or a cystoscopy. Complications can include urinary stasis, ureteral obstruction, and VUR. Severe cases may result in surgical reconstruction. Urethral valves are also known as posterior urethral valves. They are thickened mucosal folds that protrude in the posterior urethra as a congenital condition. They can cause significant obstruction to urine flow. These valves only occur in males and are usually discovered during fetal development or early infancy. Infants are commonly diagnosed using a VCUG. This is corrected by endoscopic surgery at an early age to prevent renal damage. Right, this is another highlight star. Polycystic kidney disease is a disorder where cysts are scattered throughout one or both kidneys and occurs when there is a mutation of the PKD1 and PKD2 genes. These cysts alter appearance of the kidney and may alter renal function. The appearance can be described as bunch of grapes scattered throughout the kidney. It is a congenital familial kidney disorder that can be classified as either autosomal recessive or autosomal dominant. Autosomal recessive is rare and difficult to diagnose if there is no family history of the disease, but it could be discovered via ultrasound. Autosomal dominant (PKD) is asymptomatic in childhood and clinical symptoms appear in adulthood. As a person ages, the cysts gradually increase in size, leading to symptoms such as lower back pain, UTIs, and stone formation. Diagnosis is confirmed through ultrasound or with CT showing a moth-eaten appearance of the functional renal tissue. IVU images will show bilateral enlargement of the kidneys that are not well outlined and calculeal stretching and distortion. Treatment includes good management of UTIs, basic fluid and electrolyte management, hypertension management, avoidance of physical activities that could cause harm to the abdomen, and management of pain caused by the occasional rupture of a cyst. Next, we are going to talk about the inflammatory diseases. UTIs are the most common of all bacterial infections. They can occur in anyone, are diagnosed with a urine culture, and are treated with antibiotics. Pyelonephritis is a bacterial infection of the calcaneus and renal pelvis and are considered the most common renal disease. Pyelonephritis can happen with any obstruction or stagnation to urine flow in any part of the urinary tract. Symptoms include fever, flank pain, and general malaise. Urinalysis demonstrates pyuria, the presence of pus created by the body fighting the reaction. Diagnosis is generally made with lab results as imaging is not required and radiographic findings are not nonspecific. Treatment would be antibiotics. If a person has chronic pyelonephritis that can be seen radiographically on an IVU, the renal pyramids will atrophy and give the calicus a clubbed appearance. In chronic pyelonephritis, treatment is controlling hypertension, removing any obstruction, and antibiotics. Next, we are moving on to the degenerative and metabolic diseases. Renal calculi are stones that develop from urine that hasn't properly processed crystalline materials like calcium and salts. Causes can be hyperparathyroidism, excessive intake of calcium, a metabolic rate that causes high urine concentration, and chronic UTIs. It occurs more often in males. Most calculi form in the calyceus or renal pelvis. A staghorn calculus is a large calculus that takes the shape of the pelvic calceal junction. Since the majority of the calculi contain calcium, most are visible on radiographs, IVU, RP, ultrasound, and non-contrast CT, with CT being the first modality of choice. If the stone is not passed, a lithotripsy of the stone or surgical excision may be necessary. Renal failure can be acute, but it usually is a chronic disease. The normal functions of the kidney are impaired due to the loss of the glomerular filtration and subsequent deterioration of the renal parenchyma. Uremia is a symptom of renal failure and occurs when there is retention of urea in the blood. Urea is normally excreted by the kidneys, but as the body loses its ability to properly filter waste, urea builds up in the blood and is used as a measurement to classify the severity of the disease. Creatinine and blood levels will increase while GFR decreases. Imaging may be requested to identify correctable causes of impaired renal function. An abdominal X-ray can rule out urinary calculi, and ultrasound or CT can assess the kidney size and screen for hydronephrosis. Contrast studies are generally contraindicated due to the patient's renal function, but they can be performed if medically necessary using proper IV hydration strategies and/or having the patient go to dialysis after the procedure. Because of this, we want the patient to be hydrated. We don't want them to be dehydrated or have a heart disease or have asthma, because these are predisposing conditions and increase the adverse reaction to iodinated contrast agents. That would be a highlight star. The gradual deterioration of renal function brings with its host of changes in other body systems. The individual experiences moderate anemia, hypertension, heart arrhythmia, congestive heart failure, and other problems related to the body's severe electrolyte and acid-base imbalances. Treatment of renal failure consists of dialysis and possible transplant. Hydronephrosis is an obstructive disorder of the urinary system that causes dilation of the renal pelvis and calyces with urine. The most common cause is a calculus, but it can be caused by a congenital defect or a blockage in the system. Abdominal ultrasound is the initial exam of choice, and abdominal CT is highly recommended when a blockage is suspected. Contrast use will have to be evaluated case by case to see if it is contraindicated or not. The final diseases we're going to talk about are neoplastic. Renal cysts are usually asymptomatic, do not impair renal function, and are discovered incidentally on imaging studies ordered for other reasons. In some instances, they may cause symptoms from rupture, hemorrhage, infection, or obstruction. Their cause is unknown, but obstruction of nephrons from an acquired disease can cause them. Cysts become more common as people age. It's estimated that half of those aged 50 have renal cysts. They are found more often on the lower part of the kidney and can be seen in CT, MRI, and ultrasound. Treatment is generally not needed, but aspiration can be done if called for. This is a highlight star. Renal cell carcinoma is the most common malignant tumor of the kidney. RCC is an adenocarcinoma in the cortex of the kidney. It is 2 to 3 times more frequent in males than females and is more high risk after the age of 50. The cause is unknown, but chronic inflammation from obstruction, cigarette smoking, obesity, hypertension are risk factors for the development of RCC. Hematuria, flank pain, fever, or a palpable mass are all symptoms of the disease. It can also be incidental finding on ultrasound, CT, or MRI. These tumors will have an irregular appearance of parenchyma or collecting system. They tend to grow slow and expand rather than infiltrate surrounding tissue. If caught early, surgical removal of the kidney in addition to chemotherapy has a really good prognosis. RFA and cryoablation therapies in interventional radiography can be alternative to a nephrectomy for some patients. Adenocarcinoma does have a tendency to metastasize early. Survival is highly dependent on tumor grade, cell type, and extent of metastasis. Most common METS sites are lungs, brain, liver, and bone. Nephroblastoma is a malignant renal tumor found in approximately 500 children per year. It is associated with the deletion or inactivation of the WT1 or WTX X chromosome tumor suppressor gene and may be inherited or sporadic in origin. Children with nephroblastoma often have no symptoms but may have the tumor discovered by a parent or physician who feels a large palpable abdominal mass. The relative firmness and immobility help distinguish Wilms tumor from hydronephrosis and renal cysts. They begin in the kidney and deform the normal collecting system. Diagnostic ultrasound is used extensively to differentiate a cystic mass from a solid mass. Abdominal CT is the best modality of choice for assessing the extent and spread of the tumor. Left untreated, widespread mets will occur to the lungs, liver, adrenal glands, and bone. Early removal, radiation therapy, and chemotherapy are the most effective treatment. This is also a highlight star, so bladder carcinoma is the most common cancer in the urinary tract. It usually occurs 3 times more often in males than females. Its cause is clearly related to cigarette smoking and certain industrial chemicals. It has also been associated with abuse of analgesics and pelvic radiation therapy for gynecologic cancers. Bladder carcinoma may be classified in 3 different ways: as urethrolyal carcinoma, formerly known as transitional cell carcinoma, or TCC, squamous cell carcinoma, or adenocarcinoma. Hematuria is the most common symptom, but dysuria, pelvic pain, and hydronephrosis can also be present. The tumors are generally small and located in the trigone region or along the lateral bladder walls. Cystoscopy is the method of choice for identifying bladder carcinoma, and diagnosis is made via concurrent biopsy or resection of small lesions. Treatment depends on the cancer's stage and invasiveness. Superficial tumors may be treated with a transurethral resection or ablation along with chemotherapy and immunotherapy. Invasive tumors may require resection or total cystectomy. In this case, the distal ureters are attached to a loop of bowel at the cecum or ileum. The loop bowel is usually then brought to a stoma at the skin surface known as a urostomy. A fluoroscopic injection study of this type of anatomy is called a leukogram, and it is a retrograde contrast study requiring catheterization of the urostomy and bowel segment. A leukogram can be done to evaluate patency, rule out obstruction, evaluate for post-op urine leaks, or assess for tumor recurrence. Alright, this is the end of chapter 7. If you have any questions, please let me know. These are some pathology additive or subtractive conditions if you want to look over them and use this for your assignment. A couple that I would look over are calcifications, cystitis, because they might show up in the future. Alright, have a good week, everybody.